poster presentation from the N-Momentum clinical trial. N-Momentum was the pivotal clinical trial that led to the approval of inebilizumab treatment in neuromyelitis optica, which is now approved both by the US FDA as well as the EMA and other countries around the world. In this study, MRI was used to help adjudicate attacks. So we included a number of attack criteria that didn't require MRI scans when the attacks were very clear, and then a number of minor attacks, or less severe attacks, I should say, where we wanted to confirm the attack based on a new lesion present in the area of interest by MRI. So, for example, mild loss of vision in one eye would require a MRI scan showing a new contrast-enhancing lesion within that optic nerve on the correct side. So the idea there was to simply use MRI as a tool to confirm that attacks occurred when they were clinically less severe than a very severe attack, such as a complete loss of vision in one eye, which would be an obvious optic neuritis. So we included MRI in that study. And we also performed MRI at fixed time points at baseline, at the end of the randomized control period, and then at fixed intervals during the open label extension study. And it was the only clinical trial that used MRI as a endpoint. And it's the only clinical trial that gathered MRI to date in NMO. And so it was interesting to analyze the MRI data and to see to what extent there was a concordance between the MRI data that was collected versus the clinical data. And the good news is that about 85% of adjudicated attacks had corresponding MRI lesions right where you would expect them to be. So MRI wound up being a very good measure that could help correlate clinical attacks in NMO. And this, I think, makes good sense. It's very consistent with what clinicians see in their own personal practice. If you have a patient coming in and you suspect that that patient has a cervical myelitis, you often get an MRI scan performed, often in the emergency department, and find a new contrast-enhancing lesion involving the spinal cord. So that happens a lot of the time, but not always, and the data from the trial was very consistent with this. However, we also noticed in this study, and this was new data because this is the first time that the data on MRI disease activity had been prospectively gathered in NMO, we found that there were a number of events that would occur, contrast-enhancing events that would occur, either involving the spinal cord, or occasionally involving the brain, and occasionally involving the optic nerve, that were asymptomatic. And this was, I think, a very interesting finding because we weren't really expecting contrast-enhancing events in the spinal cord to be asymptomatic. When you think about the spinal cord being an eloquent structure within the central nervous system, typically inflammation involving the spinal cord is going to produce symptoms. And we see this very frequently in NMO. But it turns out that sometimes you can have asymptomatic contrast-enhancing events occurring within the spinal cord in NMO. And we saw the same sort of thing occurring within the optic nerves as well. Interestingly, those types of events could herald a future clinical attack in the year to follow. So it wouldn't always be that a contrast-enhancing event would have an immediate clinical attack in the days or weeks to come. But down the road, we would see clinical relapses occur sometimes in association with these lesions. And this is, from my point of view, very interesting. It's almost as if there's a two-step process going on in neuromyelitis optica, where first you have inflammation, but the inflammation isn't associated with tissue injury. And then something else has to happen, perhaps to disrupt the blood-brain barrier further to allow those anti-aquaporin 4 antibodies to bind to the astroglial podocyte processes and begin causing tissue injury. So it's as if this process of lesion formation in NMO is not as instantaneous as we typically think it is, but may actually transpire over a much longer period of time. So that's kind of interesting from an immunobiology perspective. The other thing that was observed with these asymptomatic lesions is that with inebilizumab treatment, the asymptomatic lesions gradually became less and less frequent with time. So inebilizumab does have an effect on the asymptomatic lesions as well. And that's probably a good thing because some of those asymptomatic lesions could go on to become symptomatic lesions. So that's sort of that study in a nutshell. I think it's very interesting and provocative work. It's forced me to think about NMO pathogenesis a little bit in a different way because of the observance of these asymptomatic GAD-enhancing events. What is that? How does that occur? And just goes to show that as much as we understand NMO today with respect to the biology of the aquaporin 4 antibody and complement fixation and interleukin-6 activity instigating inflammation, there are many things we still don't fully understand. And so, of course, this is going to be an area of additional work in the years to come.